Okay now?
Okay, so people can see you.
Okay.
You can say 2 minutes.
Okay, so we will start the webinar in 2 minutes. So we're going to give a little bit of time for people to connect. So everyone, welcome and good afternoon.
Sí, you will see.
Yeah.
Okay, the number is increasing.
Okay.
Maybe you can say in 1 minute.
Okay, so welcome everyone. We're going to wait 1 extra minute to give time more people to meet us. So we start the webinar with Dr. Antonio Beltran in 1 minute. Thank you. Thank you.
I think we can do.
Yes. Okay, so we are going to start. Good afternoon. My name is Dr. Luis Alvarez. I'm a field application specialist at OncoDNA. Welcome to this OncoDNA seminar with Dr. Antonio Lopez-Beltran, who is the director of the Anatomic Pathology Department at the Champalimaud Clinical Center. So thank you very much for letting us be here with you in these fantastic facilities. I'm going to start just a brief presentation. I want to speak a few words to introduce OncoDNA for those of you that meet us for the first time. So OncoDNA is a Belgian company with headquarters in Charleroi. We offer solutions for worldwide cancer patients, and our studies combine the most relevant technologies for both solid and liquid biopsy and provide a comprehensive molecular characterization of the patient tumor. And therefore, we help oncologists in the treatment decision and the follow-up and the follow-up decision as well. So, of course, you can find all the information about our studies in our webpage, that is oncodna.com. And I also want to introduce Antonio Lopez-Beltran. So I have the paper, so I don't forget anything. So there are so many things. So as I already mentioned, he is the director of the anatomic pathology at the Champalimaud Clinical Center. He is also a full professor of the anatomic pathology at Córdoba University Medical School. He's the chairman of the European Working Group on Urologic Pathology and a member of the World Health Organization expert panel on urologic tumors. And also he has an impressive research career with a publication record of more than 500 papers. So in this seminar, Dr. Antonio Beltran is going to present a comprehensive summary of the utility of molecular profiling in prostate cancer, and also he's going to present an analysis of 50 retrospective samples of the OncoDNA database. So at the end of the webinar, we are going to have 50 minutes to answer questions from the audience, and I will ask you can write at any time the question on the dashboard of the GoToWebinar, and at the end we will read it and try to answer the questions. So thank you very much, Antonio, and let's start with the webinar. Okay.
Okay. Thank you, Luis, for the nice introduction.
And it is my role today to start with this presentation, which will briefly review the question of integrating molecular profiling in the clinical practice of prostate cancer. We will briefly review some molecular alterations that are common in prostate cancer in relation with their potential utility as a prognostic or diagnostic markers. We also review briefly the current status of precision medicine, some spots on immunotherapy, liquid biopsy, and so on in metastatic prostate cancer. We will comment on, as previously mentioned, on a retrospective series of cases of metastatic prostate cancer investigated using the OncoDNA platforms, and we will finish with a case study on how precision medicine can guide treatments nowadays. So concerning diagnostic and prognostic of prostate cancer using molecular analysis, it is probably important to realize that prostate cancer is the first cancer diagnosed in men in the Occidental world. Also is the second leading cause of mortality in men, just right after lung cancer. Most of these type of cancer are diagnosed at an average of 66 years of age. The characteristic of prostate cancer are histologically defined as a major type, which is also known as acinar adenocarcinoma of the prostate. In addition to this acinar adenocarcinoma of the prostate, we have a lower number of cases which belong to the category of non-acinar. In this category include a number of subtypes like ductal carcinoma, small cell neuroendocrine carcinoma, and so on, which are important because they need a specific approach in therapy and even in diagnostic features. Something which is very interesting recently is the discovery of some molecular alterations like SHLAB1 gene mutations in some of these categories. It could be some kind of differentiation markers between non-acinar and acinar carcinomas. This is something that probably the near future will be of great interest. So if we go back to the diagnostic and prognostic of prostate cancer using molecular alterations, if you go to this excellent review paper by Cucciara, published in European Urology last year, as you see here, they include 5 specific diagnostic tests that most popular is the PCA3, but there are some others like MyProstatic Score, Select MDX, ExoDX, and others. So what is important is these diagnostic tests, they use each of those, they use to detect certain molecular anomalies that can give advantages in terms of diagnosis. For instance, TEMPRS2-ERK, the fusion gene, is used by the MyProstate score, and as you see here, it used to improve prediction of aggressiveness in prostate cancer at time of biopsy. As you may notice that all these tests are done mostly in urine, with the exception of the confirmed MDX, which is done on prostate biopsy. Others, as you see here, they detect the HOX C6, the exosome-related gene expressions, methylation status, and so on. So we have a group of molecularly originated diagnostic tests. We have a good performance in clinical practice. In concerning prognostic biomarkers, the three classic tests available are the Cypher, OncoType DX, and Prolaris. As you see in this slide, they detect a number of altered genes, and as you may see also, they can be used both in radical prostatectomy or prostate biopsies, or in both, like is the case of Prolaris. And these markers will help the clinician, the oncologist, in using the proper therapy, deciding if a patient can be in active surveillance or if can be treated more definitively using radical surgery, radiation, or whatever. If we give an overview on the oncogenesis process that characterizes prostate cancer, as you see here, we can evolve from a normal prostatic epithelium to the earliest identified lesion, which is called the proliferative inflammatory atrophy, with important alterations on methylation of genes. Then we will move on to prostatic intraepithelial neoplasia, which is a carcinoma in situ of the prostate. Then will evolve into localized prostate cancer, metastatic, and androgen-independent disease. As you see, there are a number of molecular alterations defining each of these steps. The question at this moment is if these molecular alterations have the potential of being used in therapy. In this slide, we also briefly review this cancer progression status from normal, PIN, localized. It is a very important step from PIN to localized.
You have an audio. Okay, it's okay. Okay.
Again, also, it is important to notice that a marker that is the TMPRSS2 fusion gene, which can be a marker of early origin of prostate cancer, can be an infrequent alteration in more advanced disease. Also important in terms of molecular alterations, the definition of the prostate cancer is the emergence of neuroendocrine phenotype in prostate cancer. As you will see in this scheme taken from Terry S. and Beltran, normally we observe a number of cases of prostate cancer that after a certain period of therapy interventions together with environmental changes, they suffer what is called neuroendocrine transdifferentiation. This neuroendocrine transdifferentiation, it is recognized by the appearance of cells of prostate cancer of features that we recognize at histology and also biochemically as markers of neuroendocrine differentiation. This is an intermediate step that together with more genetic anomalies like urokinase, MEK gene alteration, RB gene loss, and so on, will allow to develop one of the most aggressive forms of prostate cancer, which is the small cell neuroendocrine carcinoma. Concerning the current status of precision medicine in prostate cancer management, if you see in this slide, we present a potential utility of this diagnostic and prognostics molecular test that mentioned earlier and reviewed by Cucchiara et al. In last year in European Urology. As you see here, we have, if we apply properly these markers, we can have benefits in establishing each of the potential steps in which the disease is moving across time. But also, it is very important for us to keep in mind that we have to apply different therapeutic approaches according to the status of the disease. For instance, when we have a localized disease, most probably this will be treated by radical surgery. It will be treated by occasionally adjuvant or androgen deprivation therapy, and sometimes with brachytherapy. But in more advanced disease, like when there is a biochemical recurrence, we might use not only radical surgery, brachytherapy, observation in some of these patients, but also external radiation beams in some of these patients. But when we have a castration-sensitive metastatic prostate cancer, we will be out of this surgical intervention. We will clearly move into the medical approach to this disease. In this particular group, androgen deprivation therapy, orchiectomy, some combinations of chemotherapy with anti-androgen deprivation therapy will be the treatment of choice. And if we move on to the last step of the disease, the metastatic castration-resistant prostate cancer, we will have a new set of drugs which are really changing the landscape of this patient. I mean, basically, abiraterone and salidomide as a very new and very novel drugs that are getting of great value in practice. In addition to that, we might use chemotherapy in certain combinations, some other cellular therapy like Cipuleucel and so on, and we might have an alternative second-line chemotherapy with carboplatin or mitotrexate. The question which is clear is that we don't have only one disease, and if we don't have one disease, we don't have only one treatment. Then we need to find the proper way to treat this patient. And this is true because we have to recognize that the molecular landscape of each of these cancers is different. And the way in which the patient responds to this prostate cancer might be also different from one patient to another. And these important differences are the base of what is called nowadays as precision medicine, precision oncology, or personalized medicine. If we evaluate the molecular landscape that can be used to predict sensitivity or resistance to treatment, we might have to evaluate the most common altered pathways that characterize prostate cancer. We might see here in this slide that WNT pathway, PI3K, androgen receptor pathway, DNA repair, cell cycle are commonly altered in prostate cancer. As an intervention using this molecular information, we can detect the splice V7 of androgen receptor, which is important in defining the resistance to enzalutamide or abiraterone in metastatic castration-resistant prostate cancer. We also might use the mutation, the PTEN mutations, as a surrogate to possible response using PI3K mTOR related therapies. But also this area of DNA repair gene alterations is very useful in defining the utility of PARP inhibitors and platinum cells in some of these patients. As you see here, we have a number of drugs that can help monitoring this patient and taking final decision. But something also is new and need to be discussed, although briefly, which is the role of immunocheckpoints in prostate cancer. Immunocheckpoints are very important. We know all about, and we're getting more and more expert on how to get benefit in several types of tumors using immunotherapy. But we must recognize that currently the success obtained using immunocheckpoint therapies in metastatic prostate cancer has been limited. And nowadays, more important research on this area concentrates in a combination of several immunotherapy or combination of immunotherapy with chemotherapy or other therapy family agents, and also concentrates in developing new therapies to target immunocheckpoint. But an important question remains: how can we define the optimal patient selection, which is ultimately the patient that will respond and will not? And this, at this moment, which even is not perfect, but what we have at this moment is the opportunity to increase the number of predictive markers that we can use in to monitor, to assess the potential of response to current immunotherapy. Actually, one of the fields with major expansion is the use of liquid biopsies. Liquid biopsies can be used to monitor diseases, particular cancer diseases, and in the area of metastatic prostate cancer, it has an important value in the detecting resistance to therapy before even the patients present symptoms for that. And this is, of course, an important contribution nowadays. So, in addition to these liquid biopsies, we might use serum PSA, which lacks sensitivity and specificity, is not very good marker in this setting. We could also detect other mechanistic related biomarkers, but none of them has enough power to cover this particular situation. In any case, how can we handle this particular question of resistance, the emergency of resistance to therapy? Well, we could do serial sampling, which is not invasive. We can capture tumor heterogeneity using sequential biopsies, which are invasive. And in any case, we might need using tissue biopsies, which is very limited sometimes in these patients because they are with higher age, the poor general state, and so on. So, in addition to biopsy, what do we have? So, liquid biopsies. We go back to the beginning of this slide. The emergency of resistance is a territory that actually is going to be the territory of liquid biopsy because it can give very early signs of resistance, even as mentioned before the patient itself present symptoms related to that. And it will give us, most importantly, the opportunity of earlier therapy switching. In general, liquid biopsy focused on circulating free DNA profiling. Circulating free DNA is present normally in blood. In normal non-person without tumor, the concentration of cell-free DNA is low because it's clear. But patients with cancer, the amount of cell-free DNA remain high and for a long period of time in circulation. Also, molecular analysis using this cell-free DNA have clearly demonstrated that we can demonstrate in these materials the mutations that characterize both primary and metastatic lesions, which is very important because actually we can get all the information we need on tumor heterogeneity in using liquid biopsies. Other values, for instance, in addition to those mentioned, is that we can monitor certain treatments like PARP inhibition, and for instance, an early detection of reversion of mutations that can be associated with resistance in this particular area of PARP inhibition therapy. For instance, the amount of cell-free DNA itself can be very useful to correlate with progression-free survival, with overall survival in patients in this setting of PARP inhibitors. But for instance, the presence of androgen alterations at the level of cell-free DNA is associated with reduced progression-free survival in patients treated with enzalutamide, as we can see in the Kaplan-Meier plot showing up to the right of the slide. So, what is our experience on molecular profiling of metastatic prostate cancer? So we have the opportunity to review retrospectively 50 patients with metastatic prostate cancer that had been profiled using the OncoDeep platform, which is dedicated to solid biopsy, or patients that have been investigated using the solution known as OncoSTRAT&GO, which is developed for solid biopsy to be used as a therapy support, as a prognostic support, plus liquid biopsy, mainly, again, for diagnostic, prognostic, and also for early detection of resistance to therapy. Using this combined approach, we have investigated about 200 genes in terms of mutation, fusion, and so on in this group of patients. We also have investigated between 7 to 10 proteins at immunohistochemical level, evaluating upregulation, downregulation, phosphorylation, and we also have evaluated the splice variant B7 of androgen receptor and the microsatellite instability and the tumor mutation burden. All these information are very, very helpful in defining targeted therapy, chemo, immunotherapy, and immunotherapy, each one for its own value. As we see here, the average mutations that we have seen use the small panel OncoDeep is 3.5 per sample, compared with the 22 mutations seen using the large panel OncoSTRAT&GO. Of note is that around 72% of the cases, in 72% of the cases, we can detect at least one damaging mutation, means that potential for therapy. The number of cases that fail to be detectable or to be useful for this type of mutation was less than 10%, which means it was related by the poor quality of formalin fix. Of note, these tests can be properly done using formalin fixed, paraffin embedded samples. When we evaluate the mutation observed in this particular group, most of them can be divided as a DNA repair, androgen pathway, or PI3K mTOR pathway alteration. As you see here, we have seen that V7 was observed in 40% of the samples, and in concordance with what we know, that this observation is frequently observed in castration-resistant prostate cancer. By other means, Tempers-2 fusion was observed in only 6.4% of patients, which is in accordance with an early event more than a later one. And we have also the opportunity to compare those cases in which we have solid and liquid biopsy. In these 23 samples give us some important information. The concordance between both the mutation observed in both technologies was about 42%. The majority of mutations detected in both solid and liquid were damaging, means relation with potential therapy. 70% of the mutation detected only in solid or only in liquid biopsy were of unknown significance or most probably polymorphic, of course, without known any significance. Most non-polymorphic mutations observed in this series in blood were related to TP53 mutation, 60%, which is not surprising because it's the common mutation seen in metastatic prostate cancer. But in addition to that, we also have observed mutations as KRAS, PI3K, PTEN, EGFR, LBP2, where is ESR1. So all these mutations have been related with potential targeting therapy, which is very important contribution. Another important topic is if NGS alone is better or not to combining NGS data with immunohistochemistry, as does this OncoDeep or OncoSTRAT&GO. As you see here, we could provide novel alternative therapies in about 50% of cases using only NGS, and about 90% of cases only using combining NGS and immunohistochemistry, which is actually a superior approach. The distribution of the treatments. So as you see here, about near 40% of the patients had received information with potential clinical benefit. But not only that, sometimes we have to follow the principle of non-nocere, or non-nocere, which means that if we cannot treat, at least don't harm. And these tests also provide this information using a line of group of information of potential lack of clinical benefit. So if we move on a little bit more, we can provide, using this molecular approach, chemotherapies and targeted therapies used in some of these patients, associated treatment options with clinical benefit or associated with resistance to therapy. Some of the suggested therapies are already approved for prostate cancer, about 30%, but most of the other are not, are already approved for other type of drugs that eventually can be also used in prostate cancer. And also, we showed that the superiority of using a combination of immunohistochemistry together with next generation sequencing analysis in this patient. So, just to the end, let me show you a true case that we have, one of the cases that we have studied recently. And this is a male, 60 years of age, with metastatic prostate cancer and metastasis in bones, spleens, that was treated according to the current protocols with hormone therapy, and currently is on taxane therapy. So the NGS analysis of this particular case found a big number of mutations, most probably polymorphic, a number of mutation of non-significant, and also some damaging mutation that can be used for therapy. For instance, we have observed a mutation, the STK11, which is related to mTOR inhibitors, and then provide one way to treat to this patient. Also, we have observed PMS2 mutation. PMS2 mutation is a component of DNA mismatch repair system, and inactivation of PMS2 can lead to microsatellite instability, and tumors with high microsatellite instability can respond better to immune checkpoint therapies. According to immunohistochemistry, we have observed that this particular patient had high androgen receptor expression and no androgen receptor V7 mutation. And this open benefit for androgen receptor inhibitors, as mentioned before, enzalutamide or abiraterone. We also observed a low TUBB3 expression with supporting potential utility to taxane therapy. We also observed low topoisomerase 2A expression with lack of benefit for topoisomerase 2 inhibitors. And also we have observed high expression of ERK-CC1, which is related to lack of benefit to platinum therapy. Concerning immunotherapy, in this patient, we have observed PD-L1 expression negative by immunohistochemistry, CD8 expression very low, about 1%, tumor mutation burden medium average, high microsatellite instability, and no presence of mutation of sensitivity. Based on these data, so PD-1, PD-L1 inhibitors approved for microsatellite instability high solid tumors are associated with potential clinical benefit that can be also used in this particular patient. So, as we see in this summary slide, we have detected in this particular patient the STK11 that potentially could help using mTOR pathway inhibitors. This was additionally supported by immunohistochemistry with a high expression of P4-EBP1 expression, and also the mutation of PMS2 has led to the microsatellite instability, opens the door for immunotherapy, for pembrolizumab, and maybe other drugs. And using also data from immunohistochemistry, we can also support using a chemotherapy based in taxanes as a potential benefit for the patient. This particular patient on follow-up actually is on treatment using docetaxel. In the first RECIST evaluation shows a positive response and a 3-fold decrease PSA. Immunotherapy in this particular patient was left as an alternative in case of potential future relapse. If we go to finish and before going home, some messages can be of help. Very important that the progression in prostate cancer is related to genetic heterogeneity. There are a number of new molecular studies and tests being developed for recognizing prostate cancer risk and aggressive disease, and provide a personalized approach to treat these patients. Precision medicine more beneficial, effective, because can provide information into ways in personalizing care and monitoring and early discovery of resistance. This precision medicine actually is part of the globalization of medicine, which we are also already across the world. We have to also take the message that personalized medicine, liquid biopsy, immunotherapies have the potential to improve survival of metastatic prostate cancer patients, but there are still many hurdles to overcome. So recognizing that cancer is a complex disease, and so should our treatment strategy be nowadays. Thank you very much.
Okay, so if anyone want to write a questions, we will have time to discuss. You can write on the desk of your GoToWebinar chat. Okay, so we can wait for a minute and see if anyone has questions. So, okay, there are no questions. So I want to thank Dr. Beltran for this fantastic presentation. I think you go through all the hot topics of the prostatic cancer, the profiling and molecular profiling usage in prostate cancer. And I want to thank all the audience, all the people that be with us, and hope to meet. I hope that you meet us in the next webinar. So thank you very much and good afternoon.